This conference will now be recorded.
I picked up small intestine because this is one part of the abdomen which was very sparsely covered even earlier. We had taken lectures on gallbladder and the whole hepatobiliary system, but the small intestine was never covered. So we'll start with the small intestine today. And okay, so first the acknowledgements, and this purely educative, and we have picked up a number of photographs and pictures from the internet and textbooks that we mentioned up here, just for the record. So starting with the embryology first of all, and if you look at the formation of the primitive gut tube and its layer, this is how the initial uh, picture looks like. You got the yolk sac, you got the amniotic cavity, and you got the primitive streak out here. This is from a knowledge of anatomy. You must probably be remembering it. And here you have the developing embryo, and you've got the endodermal layer out here. And this gut tube which is formed is basically from the endodermal layer which is lining the roof of the yolk sac. This is the yolk sac, and you got the roof out here, right? So this is the endodermal layer which is forming the roof of the yolk sac. And once it forms, it is closed at the two ends. So at the cranial end, you got the closure by the buccopharyngeal membrane, which divides the oral cavity, the primitive oral cavity from the pharynx, and below you got the cloacal membrane, which later disappears to form the three openings. In the female, the vagina urethrinus, and the male, just the urethrinus. And the surrounding mesoderm around the endoderm that contributes to the rest of the bowel wall, namely the lamina propria, the muscularis mucosa, and so on and so forth, and of course to the visceral peritoneum and the somatic peritoneum. Now, this is just the formation of primitive gut and its layer. We just cover this again, first of all. So what happens when you have this endodermal layer starts folding? It folds in two directions. One, it folds craniocaudally, and number two, it folds laterally. So this lateral and craniocaudal fold ultimately gives it a tubular structure. And to start with, the tube usually forms fully at the cranial end and at the caudal end. So at the head end of the embryo, you got the future foregut, and at the lower part, you got the future hindgut. So these tubes form first. The middle part remains open until a very long time, And this part which is open is gradually contracting. This opening gradually contracts because the purse string narrowing, which is just an extension of the craniocaudal and lateral folding. And this remains as until a late stage as the yolk stalk or as the Whittling duct. And this is basically the communication between the extracoelomic and now the intracoelomic coelom. It is also lined by endoderm. So at the end of the third week onward, the demarcation of the three parts of the gut are clearly definable. You can see the three parts of the gut. Now what happens is luminal changes occur. And from the fifth week onwards, the gut tube endoderm proliferates rapidly. So this tube, which was formed, the foregut and the hindgut and the part of the midgut, which was initially tubular, is now occluded. Why? Because there is a proliferation of the endoderm. Now, seventh week onwards, now recanalization commences. And this recanalization is now commencing because growth of the mesodermal wall and apoptosis of the endodermal lining, endodermal line. Now, this is true for all tubular structures in the human body. Initially, they form as a tube, then they get occluded, and then they get recanalized. So, in the ninth week, you have a complete lumen re-establishment for the gut. And during this folding, the somatic mesoderm is applied to the body wall and gives rise to the parietal peritoneum. The visceral mesoderm, we just now covered that. That is going to form the layers of the gut and gut tube, and of course the visceral peritoneum and the mesentery. The nerves and neurons are basically ectodermal, and they come from the neural crest. So these are the neural folds, and from here you got the migration of these nerve cells and the neurons. Now, this is basically a representation of the embryological parts of the gut, and you can divide them into the three parts: the foregut, the midgut, and the hindgut. The foregut extending cranially from the buccopharyngeal membrane up to the part which is ending at the ampulla vator, and that is the site of the liver bud outgrowth. And the artery to this foregut is the celiac artery, a direct branch of the aorta. And the primary function of this foregut is digestive. The midgut starts at the ampulla obvator. So you have starting at ampulla obvator here, this ampulla obvator, and it goes up to the middle and the left third of the transverse colon. See this? The middle third and the left third of the transverse colon. And the artery which is supplying this is the superior mesenteric artery. Again, a direct branch from the aorta. So here you got the celiac trunk, and next you got the superior mesenteric artery. And then you got the third part of the gut, which is the hindgut, which is extending from the lateral part of the transverse colon down up to the dentate line, which is the representation of the cloacal membrane. The disciplinary cloacal membrane is represented by the dentate line, which also form the junctional between the ectodermal and the endodermal parts of the anal canal, right? And there the supply is through the inferior mesenteric artery, and this part of the bowel has predominantly excretory function. So these are the predominant function. Doesn't mean that you can't have any secretion in the midgut, especially a lot of secretion there, but these are the primary functions of the three parts of the gut. What about the mesentery and the omentum? Now, the gut has got a dorsal mesentery, it's got a ventral mesentery. The stomach and liver are suspended and attached both dorsally and ventrally. Now, the dorsal mesentery of the stomach that remains behind as the greater omentum. The ventral mesentery of the liver, which is out here, somewhere out here, remains behind at the falciform ligament. And the part of the mesentery extending between the stomach, which is known as the ventral mesogastrium, and the liver out here forms what we know as the lesser omentum. The rest of the GI tract is suspended by a dorsal mesentery. See, the whole of it is suspended dorsal mesentery. Now, it at a later point of time, part of it may get removed or part of it may remain behind. So these parts will remain as mesoduodenum, mesoappendix, mesocolon, etc. Right? Now, what happens to the mesentery at a later point of time? Now, some portion of the GI tract would retain their mesentery, and thus they would remain intraperitoneal. But some part of the GI tract, they get opposed to the posterior wall, and the mesentery gets absorbed, or rather gets fused with the body wall. Not absorbed, it's fused with the body wall, making the organs secondarily retroperitoneal. It was initially intraperitoneal, but they become secondarily retroperitoneal. Prime example being pancreas, the duodenum, the ascending colon, the descending colon. We know all these parts, especially the ascending colon and descending colon, in certain individuals could be intraperitoneal. They could have a mesentery. More often than not, they don't. But they could be having mesentery. So what has happened there? They had mesentery when the development started, but later on, these mesentery, this part of the mesentery got fused. So this fusion of mesentery leads to the secondarily retroperitoneal organs, right? So these are the primary retroperitoneal, the intraperitoneal, and the secondarily retroperitoneal organs. So if we look at the summary of the germ layer contributions, the endoderm, we all know, now gives rise to the mucosal epithelium, the mucosal glands, the submucosal glands of the GI tract, the liver, and the pancreas. This is all endodermal in origin. Mesodermal, all the layers of the gut wall, all the layers, right up to the external muscle, the adventitia, the serosa, and then the visceral peritoneum, the mesentery, and the parietal peritoneum. Ectodermal, the neural crest neurons which migrate onto the into the bowel wall. So what is the applied importance? Why the need to know all this embryology? Because you got a number of congenital abnormalities. I'll just be naming these abnormalities here. We'll talk about each one of them separately when we talk about a specific organ. So you can have atresias of the bowel. The one which is most common and very well known is the esophageal atresia with or without a fistula. Then intestinal atresia, when you talk about the small intestine, you can have intestinal atresia. The vitreointestinal duct fails to close, a patent vitreointestinal duct. You can have intestinal duplication. That basically means that you can have two jejunums. Part of the jejunum can be duplicated. That is intestinal duplication. Or you can have a part of the jejunal or ileal endoderm getting segregated, lying like an endogenous cyst, either in the mesentery or the retroperitoneum. You could have a congenital intestinal diverticulitis, which is distinct from acquired diverticulitis. You have to remember that. A malrotation, which is purely a defect in the rotation of the gut, which we'll just cover in the next few slides. A Hirschsprung disease, we are talking about a failure of migration of the neurons from the neural crest cell onto the myenteric plexus or max plexus. That is Hirschsprung's disease. Anorectal malformations, abdominal wall defect. So these could be the congenital anomalies, and that is why we need to know the embryology of the gut. Now the gut has formed, and now what is going to happen? It is to rotate. Immediately pre-rotation, which starts in the week 5th, that means just prior to week 5, you find that the midgut is hinged at 2 points. So one, you got the duodenojejunal, and number 2, you got the colic, that is the transverse colon and the left colon, the right 2/3 and the left 1/3, right? So this forms what is known as the duodenocolic isthmus. Now this is basically anchored there. So this is the whole midgut which is anchored out here. Now what happens is that there is the loop of the midgut is convex forward, and you got the superior mesenteric artery going up to the apex of the loop, where you got the vitreointestinal duct, the artery, right? Now, what is happening out here is that there is a sudden growth in the midgut. So what happens? Now the gut escapes from here. It cannot be accommodated inside the abdominal cavity. It cannot. So what happens? It is pushed into the yolk sac or the extra-embryonic coelom. And that is what leads to a temporary physiological hernia. So what we are looking at is that during this stage, what has happened is when this development is occurring, what is happening is it is going to be pushed from here into the yolk sac. It is going to be pushed from here to the yolk sac, right? That is what is happening. So when this sudden growth occurs in the midgut, it gets protruded into the yolk sac, and that is a temporary physiological hernia. Later on, what is going to happen? It is going to go back. But there could be a scenario when this communication persists and the midgut fails to, or part of the midgut or the total midgut fails to go back into the abdomen and remains outside, a condition that we know as an exomphalos. So that is the applied importance of this stage of development, where you can have a maldevelopment. So maldevelopment at this particular stage, the non-closure, would lead to what is known as the exomphalos, right? Now, so in the 5th week, you have the extruded gut with the obliterated vitreointestinal duct, already obliterated. It is running from here, the supramesenteric artery, and it is making a taut. It is a taut running from the aorta down up to the apex of the loop. Now, this going descending branches go to the afferent loop and to the efferent. So this is the afferent part of the midgut. This is the efferent part, also known as the prearterial segment and the postarterial segment. And at this point, in the postarterial segment, you can see the development of a cecal bud and an appendix, right? Now, at this point of time, this whole thing is lying in a sagittal plane, right? It is in a sagittal plane. Now, what happens? Now the rotation starts. Stage 1 of rotation starts 5th week and completes itself by the 10th week. Now, the midgut, remember, is still in the umbilical cord. It is not gone back in. So the first stage is occurring inside the umbilical cord and the extracoelomic yolk sac, right? Now, what leads to this rotation? There is a growth of the right lobe of the liver. So what is happening? The liver is somewhere here and it starts growing. Now, when it starts growing, the sudden growth is going to push this segment, that is the prearterial segment, down. See, this is what is happening. The prearterial segment gets pushed down. So this is an anti-clockwise rotation by 90 degrees. This is 90 degrees. Okay, so the liver is somewhere here. It is going to push the prearterial segment down, leading to an anti-clockwise 90-degree rotation. And when the liver comes down, it also drags the left umbilical vein, which is the future ligamentum teres, the obliterated umbilical vein, ligamentum teres, along with it. And that's why you find that the ligamentum teres is never a midline structure. It is lying to the right of the midline in the adult, right? Now, because the umbilicus is a narrow space, see, this is a very narrow space. It's a very narrow space. So if you're going to push something down, this has to come up. So when the prearterial segment goes down, at the same time, the postarterial segment is going to move up. So instead of the sagittal orientation before the rotation started, now you have a transverse orientation. So initially the pre-arterial and post-arterial were lying sagittally inside the umbilicus, and now they are lying transversely. So they have rotated anti-clockwise by 90 degrees. Now the problem in this rotation is that this pedicle, which is known as the duodenocolic pedicle, we just now referred to that, may either be very narrow or it could be broad. and that is where the applied importance lies. If it is a very narrow pedicle, remember it can easily undergo rotation even in the adult, and that will lead to what we know as the midgut volvulus. So this rotation has occurred, and the pedicle, the size of the pedicle, or the breadth of the pedicle, or the broadness of the pedicle would determine whether this patient could be having a scenario which could be a scenario where he or she can develop a midgut volvulus at a later point of time. Right now, so at this stage 1 defect, what could happen? The rotation never happened. The rotation never started, and without this rotation in stage 2, everything went back. So if there's an arrest in the development stage 1, the duodenojejunal junction does not lie inferior to the left of the superior mesenteric artery, and the cecum does not lie in the right lower quadrant as it should. Now normally what should happen? Normally what should happen is that you should be having a cecum here, you should have transverse colon here, and you should be having the DJ junction here, not here. It should be lying out here. But in non-rotation, what has happened? There's no rotation. So everything related to the small bowel lies on the right side. Everything related to the large bowel lies to the left side of the abdomen. Right? That's number 1. Number 2, you have this very narrow DJ junction. Duodenocolic pedicle, a very narrow duodenocolic pedicle. This is the pedicle, right? So you have a classic malrotation, and this is how it would look like. The small bowel, the cecum, and the ileum. Now the ileum could be entering the cecum from the right side as opposed to the left side in an adult, or it could be entering from the left side. That doesn't make a difference. Could be happening either way. Right? So this is the rotation that is supposed to occur. Now it didn't occur, so what can happen? Now you can have a rotation in the post-operative period, in the post-birth period, which can lead to what is known as the volvulus. See how it occurring. See, this is the volvulus occurring. And when this kind of orientation occurs, you could have attachment of the cecum to the parietal peritoneum here, which is going to go across the duodenum, what is known as the lat span. So these are basically all the defects in the stage 1 rotation, where you have number 1, the placement of the bowel at the wrong positions, number 1. Number 2, you could be having a very narrow duodenocolic pedicle. Number 3, you could be having a lat band, and number 4, you could be having a volvulus, which is basically a rotation across the narrow duodenocolic pedicle. Okay. Now we come to stage 2. Now what has happened? The rotation had occurred, and now the prearterial segment and the postarterial segment are lying transversely. Now the gut starts returning back into the abdominal cavity. So stage 1, which was from 5th week to 10th week, was basically a stage of rotation inside the umbilical cord. Now what is happening is the bowel is going to come back, and this starts week 10th and 11th. That means for those 2 weeks, now the bowel is going to return back. And how does it return back? The proximal part comes back first. That means it is going to retract back. It's going to retract back. The proximal comes back in. Then this one will come in. Then this one will come in. So it is the proximal part which is going to come first back into here. Now, when this return is occurring, the superior mesenteric artery is still fixed. See what is happening? See the part, the prearterial segment is gone in. So if it has to go in, and if the superior mesenteric artery is still lying taut, where can this bowel go? It has to go behind the superior mesenteric artery. So the stretched superior mesenteric artery would be the part behind which the proximal prearterial segment, this is the prearterial segment, is going to come back into the abdomen, leading to a further 90-degree rotation, again anti-clockwise. So it was lying here, and now it is going here, again rotating, And what is it going to do? It is also going to push the mesentery of the postarterial segment behind. It's going to push it, of the hindgut lying in the midline to the left. Thus, the descending colon comes to lie on the left. See, this is the descending colon. It is pushed. Pushed by what? By this bowel returning back. This is what is happening. This is what is happening. Okay. So that is the stage 2, and the last coil of the ileum, when it comes back in, that is going to bring the superior mesenteric artery back into the abdomen. Now, the cecum still lies, so this is retracting back. The cecum is lying in the umbilical cord, and cecum now reduces, passing upwards and to the right. See, all thing was going behind the superior mesenteric artery, small bowel, but the cecum is now going to go up and to the right. The last 90-degree anti-clockwise rotation that completes the 270 degrees rotation from the original plane of the pre-arterial and the post-arterial segment. And when the colon or the post-arterial segment is going to go across, it is going to cross the superior mesenteric. See, it is crossing the superior mesenteric artery. So the small bowel goes under the superior mesenteric artery. The post-arterial segment goes above the superior mesenteric artery. Easily imaginable if we just remember this figure. This is basically the umbilical orifice, and here this is going behind the superior mesenteric artery, and this is going to flip. This part is going to flip like this. It is going to go in front. This is going to go behind, right? So that is stage 2 of the midgut rotation, which completes the 270-degree. So stage 1, it was 90-degree rotation inside the umbilical cord. In stage 2, the remaining 180-degree rotation inside the abdomen while the bowel is coming back into the abdomen. Now, incomplete rotation in stage 2, what's that going to lead to? Number one, the arrest leads to incomplete rotation, which is one of the more important causes for congenital obstructions. And you can have the typical peritoneal band that we just now showed you. This band running across the cecum to the mesentery, compressing the third portion of the duodenum, what we know as the Ladd's band. You can have a displaced ligament of Tietz. The cecum lies in the epigastrium of the left hypochondrium, easily imaginable. How much rotation was completed prior, whether it was total malrotation, partial malrotation. There you can have the relative positions of the small bowel and the large bowel. And in all these malrotations, remember, internal herniations could occur. These are potential scenarios where you can have paraduodenal hernias, you can have mesocolic hernias, and so on and so forth. Coming to the stage 3 of rotation, and in this stage of rotation, which occurs from week 11 to birth, here the finalization of the 270 degrees has already occurred, and here it leads to fixation of the parts of the bowel. Now, when the fixation of the parts of the bowel occur, there is elongation of the cecum. See, elongation, it's now coming down. So it elongates. The growth of ascending colon and cecum occurs. It comes down. The post-arterial segment now becomes the transverse colon. Parts of the cut, that means the cecum, the ascending colon, they become retroperitoneal. Why? Because the dorsal mesentery of this part fuses. Similarly, the dorsal mesentery of this part fuses. So that becomes retroperitoneal, fusing with the posterior parietal peritoneum. And the small gut mesentery fixes to the posterior abdomen. So that is the third stage of rotation. Incomplete fixation, the defects in stage 3, you can have potential hernia pouches, you can have left mesocolic hernia, which is a possible entrapment and strangulation of the bowel with the descending mesocolon. You can have volvulus of the terminal ileum, cecum, proximal ascending colon, if the cecum remains unfixed. So see, each stage of rotation could have its own defects, and they can all give rise to very well-known causes of congenital obstruction. This is how it looks like. This is another figure starting from the embryo, the lying inside the umbilical cord. See, this is the anti-clockwise rotation occurring like this, and this is the final figure that we have in the patient, right? Now, looking at the anatomy of the small bowel, it is on an average 6 meters. Take it as 6 meters on average, approximately 20 feet. There's a wide variation from 3 meters to 8.5 meters. 9 feet, 27 feet, but we always take it an average of about 6 meters. Now, any disease, traumatic injury, vascular accident, any pathology where the bowel has been resected, if there is less than 200 centimeters of viable small bowel, or there's a loss of 50% or more of small intestine, these patients would develop a short bowel syndrome. This anatomical fact is very important. You have to remember that. Why? Because suppose you open the abdomen, you find a small bowel volvulus which has undergone gangrene and you want to resect it. You have to keep in mind what could be, number one, a highly morbid resection. If you find that you're leaving behind less than 200 centimeters, you have to remember, or you have to be careful that in the post-operative period and later on in life, this patient will be having short bowel syndrome. So remember, 200 centimeters or half the length of small bowel is required to obviate short bowel syndrome. What is the critical small bowel limit? Small bowel length. Critical basically would mean what is compatible with life. If you have a normal functioning colon, then the cutoff point is around 60 centimeters small bowel. That means from 6 meters, if only 1/10 of the bowel is remaining behind, but you have a normal functioning colon, you can still live. You will require a lot of supplementation, but you can live. But if the colon is absent or non-functioning, then you require at least 120, that is double of 60, roughly 120 centimeters of small bowel would be required to maintain life. So remember, number one, for having or for not having short bowel syndrome, minimum required bowel is about 2 meters, right? For being compatible with life with a normal colon, minimum 0.6 meters or 60 centimeters. For compatibility with life without colon, minimum length of small bowel required would be about 115 centimeters. Okay, that is part one. Number two, the mesenteric attachment. If you look at the surface marking, extending from left of the L2 vertebrae to the right sacroiliac joint. The blood supply, we know, comes from the supramesenteric artery, a direct branch of the aorta. The venous drainage goes back into the supramesenteric vein, which combines with the splenic vein at the neck of the pancreas to form the hepatic portal vein. The lymphatic drainage into the supramesenteric nodes and the nerve supply, the sympathetic flank nerves, referred to the periumbilical region, because most of the time any small bowel pain would be referred to the periumbilical region. Why? Because the majority or the major supply, the sympathetic supply which carry the nerve fibers which comes to the small bowel are from T10 segment, that is the sympathetic out supply, and parasympathetic is from the vagus. If you look at the layers of GI, the general organization, you would have the mucosa, the submucosa, the muscularis mucosa, and the serosa. Mucosa, you have the epithelium or the endothelium that we know of. Just underneath, you got the lamina propria, and underneath that would be muscularis mucosa. Then comes submucosa, that's coming from inside out. Submucosa, which has got the mesenteric submucosal plexus, and muscularis, the circular longitudinal muscle with the orbiX plexus, and of course the serosa or adventitia. These are the layers of the GI. Now, in anatomy, you open the abdomen, you have to identify what is jejunum, what is ileum. How does it help you, or what could be helping you identify? Number one, the color. The jejunum is red, the ileum is pink. The length 40% and 60%. So remember, 40% of jejunum. So the primary length of the small bowel is ileum to the tune of 60%. Jejunum is 40%. Position of the jejunum is primarily the left upper abdomen and central abdomen, in contrast to ileum lying primarily right lower and central abdomen. The lumen is wider in the jejunum, but less than 3 centimeters. Ileum is still narrower, less than 2 centimeters. Wall is thicker in jejunum, ileal wall is thinner. The mucosal folds or valvulae conjunctivis, also known as Kerckring folds, walls, or plicae circularis, they are large, deep, and more numerous and thicker as 2 to 3 millimeters in jejunum. But as you go down into the ileum or to the terminal ileum, these tend to disappear. So valvulae conjunctivis would not be found in the terminal part of the distal ileal segment. In the rest of the ileum, as they go down from jejunum, they become thinner and thinner, and they reach about 1 to 2 millimeters. They become more sparsely. That means the distance between these two walls increases. If you look at the Peyer's patches, the reverse is true. You got scanty Peyer patches in the jejunum, but maximum in the ileum. You got a large number of a huge concentration of Peyer's patches in the ileum. The mesentery is thin in the jejunum with minimal fat, so vessels can easily be seen. If you remove a part of the bowel, you're not able to see the mesentery. You can be sure you're not able to see the vessels through the mesentery. You can be sure that you have an ileum in your hand. Why? Because there is abundant fat in the mesentery. It is thick, and vessels are not clearly seen in the mesentery of the ileum. They're very well seen in the mesentery of the jejunum. And if you look at the mesenteric arcade and the vasa recta, which are straight arteries in the mesentery, you'd find that the arcades are much less or few in the jejunum, and you have a longer vasa recta as opposed to ileum, where you got more and complex vascular arcades and very short vasa recta. Look at the physiology. The absorptive is basically nutrients absorption, water, and electrolyte. The absorption occurs mostly in the first 100 centimeters of the jejunum. Most nutrients. That basically means the carbohydrate, the proteins, and the fat. The B12 and bile salts are absorbed in the last 100 centimeters of the ileum. This way it's easy to remember. First 100 centimeters jejunum, last 100 centimeters ileum, you got B12 and bile salts. Magnesium, terminal ileum, proximal colon, water and sodium absorption throughout. If you look at the differential, the jejunum has fats absorption, which are broken down by the pancreatic lipase and bile salts, and then absorbed into the lacteals of jejunum. Carbohydrates, proteins are hydrolyzed by pancreatic enzymes and then absorbed in the jejunum. Fluid, electrolytes, folate absorption is important. Iron absorption is important. Calcium absorption. These three are important parts to be absorbed in jejunum. But this has got a bearing when you go in for the jejunal resection. If you have a jejunal resection, you can be sure that you may have to supplement iron to this patient. You have to supplement calcium to this patient. That's why this knowledge is important. In the ileum, on the other hand, the bile salts and enterohepatic circulation is very, very important. If you go in for ileal resection, the enterohepatic circulation gets blocked or it gets cut off, and this forms a very scenario where you have a high incidence of gallbladder stone formation. Vitamin B12 deficiency, again, if you got a ileal resection. So why? Because vitamin B12, bile salts, and fat soluble vitamins are in the ileum, especially in the terminal ileum. The synthetic function of the small bowel. So when you talk about physiology, one is absorptive function, the second is synthesis function. So what does the small bowel synthesize? Number one, it synthesizes the lipoproteins. And why these lipoproteins are important? Because they're required for the transport of the absorbed dietary fat into the systemic circulation through the lymph. That is very important. So all these lipoproteins. Now these lipoproteins, they have got a problem with your lipid profile. Your cardiac risk patient, if you got many of these lipoproteins running haywire, some of them are harmful, some of them are useful. So, but otherwise, the physiological function of lipoproteins is always there. That is for as a carriage for the absorbed dietary fat. Synthesis of number of gut peptides or hormones, which is very important. Why? These hormones are there to interact with the enteric nervous system, and they modulate the intestinal and extraintestinal function, growth, and differentiation. Number one. Number two, these peptides are secreted primarily in the ileal endoendocrine cells. So the primary synthesis and excretory function of the peptides is primarily in the ileum from the L cells. And that is in response to either dietary nutrients, which carry out a direct stimulation, particularly glucose and fatty acids, or through neuronal stimulation. They are all produced from the proglucone gene, and despite similarities in their production and release, most of them, or they may be having differing action or even opposing effects. And the primary ones to be secreted are four. Number one, the glucagon-like peptide 1, 2, peptide YY, and motilin. Right? Four important peptides, and these are the physiology of GLP-1 is very important. Why? It is now being recognized more and more as a very important component of any bariatric surgical procedure, very important component of understanding metabolic surgery and its effect on diabetes. So what is it? It's known as an incretin. It's got a very short half-life. See, 1 to 2 minutes. Only 25% of newly secreted hormone leaving the gut intact. The rest of it is metabolized, secreted from the L cells by direct stimulation. I just now told you, indirect neurohumoral stimulation, hormonal stimulation, right? 6-time increase after carbohydrate meal. See, this is very important. You have a carbohydrate meal, rich carbohydrate meal, you find there is a 6-time increase in your GLP-1 level. What does it do? Number one, reduces the food intake, decreases appetite, slows the gastric emptying, stimulates the insulin, That means it is improving the insulin sensitivity and it is improving the glucose absorption. So the glucose disposal in your whatever you taken is easily done with stimulation of insulin and insulin sensitivity. Increases and maintains the beta cell function. And together, this whole action is known as a ileal brake mechanism. Ileal brake mechanism. Why? Because this all tends to control your sugar level. It's going to control the sugar level. How? By decreasing appetite, slowing your gastric emptying, stimulating the insulin to have more action. More of glucose is being metabolized. So it is ultimately going to control your glucose level. That is why in diabetes, one of the primary abnormalities is a decreased GLP-1 level. If you have a decreased GLP-1 level, you find that you have got diabetes. And that is potential therapeutic nature. The therapeutics now is that if we can somehow modify the GLP drug treatments could be there for diabetes. And that is exactly what happens. You have GLP analogs in clinical usage now, which are being used for diabetic patients, the exenatide, the liraglutide, and the lvglutide. These are in clinical usage. These are not just hypothetical drugs. They are being used, and they're all synthetic GLP-1, and they would control the glucose level by stimulating the insulin secretion. On the other hand, the GLP-2, which is activating the GLP-2 receptor located on the enteroendocrinal cells, it is basically enhancing number one, dextrose transport, that is the carbohydrate transport. Number two, stimulatory effect on intestinal lipid uptake. So that means helping number one in the glucose uptake and number two in the lipid uptake in the healthy person. What about the third one? And that is peptide YY. Peptide YY concentration in the circulation, it increases the postprandial and decreases by fasting. So all these four ingredients or these peptides, they are all controlled or they are all stimulated when you have a diet. So increases the postprandial and decreases by fasting, secreted by the endocrine cells in the ileum column. Just as I said, these are the L cells, and it exerts its action not directly but down regulating receptors known as neuropeptide Y receptors. And where these receptors found? Located throughout the body, the CNS, especially the hypothalamus, the spinal cord, the sympathetic system. And what do these receptors do? They stimulate to do what? They reduce your appetite. They inhibit your gastric motility and emptying. They suppress your pancreatic excretion. They increase the water electrolyte absorption in the colon. So together this action again what we now know as the ileal brake mechanism. Now PYY are there are two types of PYY. The PYY or peptide YY336, one of the two forms, it further suppresses appetite and promotes weight loss. So see, this is again an important function as far as the bariatric surgery is concerned. So all this has got a bearing on the bariatric surgery. So you have to understand the physiology of this part. And then the last one, the physiology, and that is the oxyntomodulin, again secreted from the same L cell. It is a weak incretin. It does not have the same effect as GLP. Why? See, it has got 50 times lower affinity as compared to GLP. So it is 50 times less potent as GLP, but still it is an incretin. And it has got a central acting satiety effect. That means tells the body as soon as secreted, it tells the body, look, I've had enough, no more eating. Effect on slow gastric emptying, that means less emptying of stomach, and of course it increases energy expenditure. And that is why these all four are very important as far as understanding the pathophysiology of diabetes is now concerned. Number two, understanding the beneficial effects in carrying out bariatric surgery and which procedures to carry out. This is just an overview of the investigations. We'll not be going to the details of the investigation at this point. We'll talk about these investigations when we talk about the specific disease process. But the investigation usually covering the small bowel relate to the contrast studies, and these contrast studies include the barium contrast. You can have enteroclysis. Barium follow through is when you have barium orally, it goes to the esophagus, the stomach, the small bowel, large bowel, so on and so forth. That is a follow through. That means you're following it through from the oral cavity through up to the anal canal. That's why it's known as barium follow through. You can have an enteroclysis. Enteroclysis basically means that the contrast that you're injecting is directly into the small bowel. It is not being taken orally. That is why enteroclysis, direct introduction into the proximal small bowel. If you're introducing the same thing into the distal small bowel, that the ileum, it is known as a enteric enema. So enteroclysis is direct injection of the contrast, which could be barium or any other contrast into the jejunum, directly jejunum or ileum, and enteric enema, retrograde injection of the contrast through the ileocecal wall into the ileum. Then you can have endoscopy, which is a peroperative or a capsule endoscopy, because entering into the jejunum becomes difficult, but the proximal jejunum can easily be covered from the oral route. The terminal ileum can be covered from the colonoscopic route. With the colonoscopic, you can go beyond the ileocecal junction into the terminal part of the ileum. You can do that. Or best, which is now available, is what is the capsule endoscopy. You take a capsule which has got a camera inside it. It goes into the jejunum and the signals, and you can see a clear-cut picture of the whole of the luminal of the lumen and the luminal walls. So this is what is a capsule endoscopy, and then ultimately this capsule comes out the oral route through the anal route, and it's washed and it is preserved. So you can have a capsule endoscopy. You can do a laparoscopic, and of course the CECT and the MRI. I have not mentioned ultrasound. It does have a role to play, but the ultrasound does not have a major role to play as far as small bowel disease is concerned. But nevertheless, ultrasound should be mentioned as a possible investigation. Now, just dealing with one disease today, and that is Crohn's disease. We'll finish after that, but this is a fairly extensive disease. So this is known as inflammatory bowel disease. Now, what is the definition of inflammatory bowel disease? Number one, it should be non-specific inflammation. Number two, it should be non-infective. You can't identify a particular infection, right? For example, say it's a tubercular infection, or say it's a typhoid infection, or say it's a bacterial infection. No, it should be non-specific inflammation, non-infective, and non-ischemic. Only then you like to call it an inflammatory bowel disease. And the inflammatory bowel disease of the small bowel is Crohn's disease. If you look at the incidence of Crohn's disease, 5 to 50 in a lakh of patients. Females are slightly more than males, not too much. And you got two peaks to the disease. Peak number one is in the age group of 25 to 40 years, and the second peak is around 70 years. 3 times more increasing trend across the last 4 decades. Now, across the last 40 years, we have been finding more and more patients of Crohn's. In fact, 3 times more patients of Crohn's as 40 years back as of today. The reasons could be two. Number one, it could be an actual increase, or it could be that you are basically identifying more of these patients. So the diagnostic capability has improved. That could be a reason for that, or there could be an actual increase. More in the Western world, more Caucasians, and 3 to 4 times more in Jews, especially Ashkenazi Jews. But what is very funny and what is very significant is that these same Jews, when they're living inside Israel, they don't have an increase in the incidence of Crohn's disease. But the same Jews, when they live outside Israel, they've got 3 to 4 times more. That probably tells you something, and that is that probably some environmental factor is also at play. What is the etiology? As you said earlier, inflammatory bowel disease, it is still unclear. Is it inflammatory, Mycobacterium paratuberculosis? We don't know. Immunologically induced vasculitis result in focal ischemia? We don't know. Food induced? We don't know. So these are just hypotheses. But what we do know is that smoking increases the risk by 3%, a very well documented fact. And that is why one of the primary advices in the treatment is stop smoking immediately. Oral contraceptives may or may not. Combination infectious agents, defective mucosal barrier, probably yes. Abnormal host response to intestinal contents, probably yes. Abnormalities of chromosome 16/6 HLA regions has been found. Then genetic defects has been identified in a few Crohn's patients. And what is true that it does have a genetic basis is also borne out by the fact that 10% of families, they have a disease first degree relative. So if you've got Crohn's disease, in 10% chances that probably one of your relatives, the first degree relative, were probably having it, and 50% incidence of Crohn's disease is found in monozygotic twins. So it does have a genetic variant. Now, if you look at 3 common sites of intestinal involvement Crohn's disease, number one, the ileum, the most common. Number 2, ileocolic, and of course the colonic. Three primary sites where you have involvement of the bowel in Crohn's disease. This is how it looks like. See the intramural thickening, all layer, and fat and thickened wall. See fat deposition. How thick the endothelium is. See this endothelium, very thick. The muscle is also thick. Compare this muscle with the rest of the bowel. So very thick muscle. So there is a intramural layer of fat and thickened walls that is always there. And if you look at the mucosal surface, you'll find this typical serpiginous ulcers with sticking slough on it, right? So these serpiginous ulcer with the slough sitting on it. So if you look at the pathophysiology, we know all those etiological factors which were probably yes, no. But what we know is probably the baseline or the bottom line is that there is increased gut permeability along with an altered immune-mediated response to it from unknown member of normal commensal gut flora. So you got a number of bacteria inside the bowel. We all know that. These are normal commensals out there. So probably one of these bacteria is leading to an altered immune-mediated response in the body. So as of now, what we now believe is that it's a combination of increased gut permeability with an altered immune-mediated response in the body, which is responsible for the ultimate manifestation of a Crohn's disease. What about the increased gut permeability? What does it do? It leads to translocation of unknown luminal antigen. We still don't know what the antigen is. Induces localized and generalized cell-mediated inflammatory response. So once the antigen gets absorbed, it stimulates your immune system to give rise to a localized at the particular site and a generalized cell-mediated inflammatory response. Cell-mediated would basically be meaning lymphocytic responses and of course monocytic responses. Release of inflammatory cytokines occurs at the same time. So apart from the cell-mediated response, it also stimulates the body to release a number of inflammatory cytokines, and the two most important ones are interleukin-2 and tumor necrosis factor. Interleukin-2 and tumor necrosis factor, two of them. The whole process is allowed to propagate. Why? The body should take care of it, but it's not taking care of it. That is where the altered immune-mediated response comes into play. And what is probably occurring in this patient who has a Crohn's disease is that there is an associated deficient T suppressor cell function. Now, T suppressor cell is important to suppress all unwanted inflammatory responses, unwanted immune responses. But that's not happening in this patient in a Crohn's disease. So that is why I say it's a double-pronged attack. Number one, the probability leads to the antigen creating havoc inside the immune system, and at the same time, the control mechanism is gone. It is no longer being controlled by your T suppressor cells. If you look at the pathology, how do we recognize a Crohn's bowel? Now, it can occur from any part. We said that the three primary sites, these are three primary sites, but that doesn't mean these are the only sites where it occurs. See, it can occur from any part from the oral cavity to the anal canal. Crohn's can occur from the oral cavity down to the anal canal. It is a different matter that 60% is ileal, with or without colonic involvement. 30% large intestinal. Perianal 50 to 75%. See, a very large percentage has got a associated perianal component. In 25% of patients with small bowel, you will have a perianal component, and 75% of patients with Crohn's disease colitis would be having a perianal component. That means if you got small bowel Crohn's disease, the chances of having a perianal Crohn's would be 25%. If I am having a Crohn's disease of the colon, the chances of having a perianal Crohn's would be 50 to 75%. The other parts, stomach and duodenum, less than 5%. Skip lesions are the norm. Now, what are skip lesions we talking about? What we are saying is that the mucosa is not uniformly inflamed. No, there are patches of inflammation. A patch here, ulcer here, and the rest of the mucosa is normal. Again, patch appears. That is what is known as a skip lesion. So skip lesion is very common in patient Crohn's disease. The skip lesions are the skip lesions in the mucosa. Stranding or wrapping by encroaching mesenteric fat is very common. When we take out the intestine out of the abdomen, we find that the fat, which should be restricted to the mesentery, it is now creeping onto the bowel from the antimesenteric border. So you'll find the fat onto the onto the bowel. That is what is known as wrapping by the encroaching mesenteric fat in the anti-mesenteric border, from the mesenteric border. Intestinal thickening with strictured lumen. So we said that there is always a hypertrophy. Why? Because of infiltration. So there's intestinal thickening. And along with this, you have a stricture of the lumen with proximal dilatation. Strictured area, if you look at the mucosal surface of that particular area where stricture is occurring, you'll find a snake-like mucosal ulceration in the strictured area. Ulcers, what is the shape of the ulcer? Either a railroad track appearance or a bear claw appearance. So either you have a bear claw appearance or you got a railroad track appearance of the ulcer, which are found, which are serpiginous ulcers on the mucosal surface. Edema between the ulcers gives rise to the cobblestone appearance on contrast study. A very, very typical appearance in a barium contrast or any other oral contrast study, what is known as a cobblestone appearance. We'll show them later on. Transmural inflammation causes what? Adhesions and fistula formation and mesenteric abscess. These are all macroscopic presentations, right? Mesenteric thickening and enlarged mesenteric lymph nodes. On the other hand, if you look at the microscopy, you take a section of a part involved with Crohn's, you'll find number one, infiltration by chronic inflammatory cells. What cells are we talking about? The lymphocytes, the plasma cells, the monocyte macrophage system. All these are chronic inflammatory cells. You'll find granulomas, giant cell granulomas. And then how do you differentiate from tubercular granuloma? It's the same granuloma, except for one important thing, and that is non-caseating giant granulomas are more common in a patient of Crohn's disease, and 60% most common in anorectal disease. So if you have an anorectal Crohn's disease, you've done a section, you'll find non-caseating giant cell granulomas. Multifocal arterial occlusions in the muscular propria, that means the proper muscle layer, muscularis propria, and nerve cell. This is muscularis propria is basically the muscular layer of the mucosa, and nerve cell hyperplasia, right? The clinical presentation of Crohn's disease can either be acute or a chronic presentation. Fortunately, acute presentations found only 5%. The rest 95% is chronic presentation. The acute presentation of 5%, it resembles acute appendicitis. Exactly resembles acute appendicitis, and often it becomes very, very difficult to differentiate between the acute appendicitis and the Crohn's disease. And how does it present apart from acute appendicitis, resembling acute appendicitis? It could be a perforative peritonitis. It could be an acute colitis with or without toxic mesocolon, and of course the chronic presentation. So the acute presentations are important in the form of either mimicking acute appendicitis, mimicking acute intestinal obstruction, or mimicking actual perforation, or mimicking a toxic megacolon. Now, the presentations would differ whether it is the small bowel or the colonic manifestation. When you talk about small bowel disease, the intestinal colic with or without diarrhea, and it is long-term over months. So that is the chronic presentation we're now talking about. And these are the patients who present with chronic diarrhea, regular intestinal colic. If they come to you, I have had this pain in the perineum lateral region for the last so many years, and I am having diarrhea also. Right iliac fossa pain, the appendicitis pain, the intermittent fever, anemia, weight loss, all understandable because the part of the ileum is being involved, part of the jejunum is involved. Perineal abscesses or fissure or fistula is another presentation. You can be having subacute intestinal obstruction, adhesions, fistulas inside the abdomen in the form of fistulation between two parts of the bowel, enteroenteric, enterosigmoid, entrovesical with the bladder, and of course enterocutaneous, where you got a fecal fistula presentation. Perforation can occur, and a questionable increased risk of small bowel cancer. Does it really occur? We don't know. We don't know. Conflicting reports are there both for small bowel cancer and colonic cancer, and you find that there are studies which show that there's a cumulative risk of almost 8% at 30 years. More common if diagnosed at younger age, more common in long disease duration, that means more than 8 years. Hence, regular colonoscopic surveillance every 1 to 3 years in such patients is the norm, and that is the standard of care. That's why, whatever the relation to colonic malignancy, it is there, it is doesn't there, it is not important. What is important that if the patient has been having a disease for more than 8 years or at a younger age, this patient should be under proper colonoscopic surveillance carried out every 1 to 3 years, and that should be the standard of care, right? The anorectal presentations are very important because remember we said that almost 75% of Crohn's would be having some manifestation of anorectal disease in the form of number one, anorectal strictures, which could be dense and fibrotic. You could have a sphincteric involvement with abscess formation, very late stages of Crohn's disease, neglected patients. They often come with incontinence. And why does incontinence occur? Because there is a sphincteric involvement with abscess formation, destruction, and fibrosis. You can have perivaginal fistula. You can have a rectal mucosa. It's usually normal when you do a DRE, or you could be having a granular or thickened rectal mucosa. If you look at the perianal skin, you can find superficial or deep ulcer, which have bluish margins and undermined, usually multiple fistula. And they can also be presenting with a water can perineum, which is nothing but a loss of urine through the perineal area through multiple openings. That is what known as water can perineum. You can be having a perianal tag of fistulae, perianal abscesses, and of course, dense perianal fibrosis. The whole of the perianal region becomes strictured and there's a loss of subcutaneous fat. Now, Montreal's classification of Crohn's disease is important. Why? Because based on the phenotype, that is the clinical presentation, it provides number one, a baseline for comparison among patients, groups, and it allows overview of your progression of your disease. A very simple classification. You just have three things to remember: age at diagnosis A1 to A3, location L1 to L4, and of course behavior B1 to B3. You have an add-on, and that add-on P is perianal, which can be added on to B1, B2, B3, because remember we said that perianal disease is there in almost 75%, and this would have some kind of implication. Let's see the first one: age at diagnosis, less than 16 years, 60 to 40, and 40 years. Upper GI small bowel location, more common. Patients are diagnosed before 20 years. A1, that is an aggressive disease. Why? Because it's going to remain there for a long period of time. Chronic disease usually found in the older age group. So the small bowel usually A1, A2, chronic A3. As far as the L4 is concerned, upper GI would be including what? Esophagus, gastroduodenal, jejunal, and greater morbidity with untreated disease. As far as L4 is concerned, modify used if upper GI disease is present in addition to L1, L3. What is a modifier? Modifier basically means you can add L4 to L1. So you can have L1, L4, L2, L4, L3, L4. That tells you that these L1 to L3 are the common sites, and you can have an uncommon site along with these. That's why it's known as a modifier. Similarly, in B1 to B3, you have a modifier. You can have inflammatory, stricturing, and penetrating. How does this help you? It immediately helps you. Inflammatory, you know, it can be treated with medicine. Stricturing, penetrating, you know, it has to be treated by surgery. So that is why this classification becomes important. So B1 responds best to medical therapy. B2, B3 is known as aggressive disease. And why? Because there is an increased likelihood of surgery in these patients. And you add a P to it, which is again a modifier, and that P could be with a B1, it could be with B2, it could be B3, right? So this is the Montreal's classification, accepted by a number of people and still not accepted by many, but because it is mentioned in a number of textbooks, including Love Bailey and Schwartz and Christopher, so we will know what, we have to know what Montreal classification is all about, and it also helps by judging your progression. When you come for the first time with Crohn's disease, your Montreal classification is done. After subsequent therapy for let's say about 3 months, 6 months, 1 year, you can decide whether I'm going ahead, or I'm heading towards surgery, or I'm going to respond to medical therapy. So it helps in that. Now, the extraintestinal manifestation is also important. I wouldn't be going through the whole list, but just remember that these are similar to ulcerative colitis. And what you have to remember is the musculoskeletal pain, the dermatological manifestations, the aphthous ulceration of the mouth, the ophthalmological manifestations. So it is almost the whole part of the body which is involved. Urological manifestation, hepatobiliary, gallstone very common, primary sclerosing cholangitis less common. Thromboembolic diseases can also be found in Crohn's disease. So you have a whole range of a number of associated extraintestinal manifestation. What is important when we talk about the extraintestinal manifestation is whether that manifestation is related to your disease activity or not. What are related to the disease activity are certain important conditions which would vary with the intensity of the disease. But if you have a less intense or more intense, there are others which would not be related. And these are the gallstone, the renal calculi, the sclerosing cholangitis, active hepatitis, sacroiliitis. So these are unrelated to your disease activity. Gallstones are very common in these patients. Why? Because you're breaking down the enterohepatic circulation because of ileitis. So if you have a breakdown of the enterohepatic circulation, obviously there will be more incidence of gallstones. Fortunately, primary sclerosing cholangitis is very rare in a patient of Crohn's. It is more common ulcerative colitis. We will talk about that when we talk about comparison of Crohn's with ulcerative colitis, because both are inflammatory bowel disease. One is primarily of the colon, the other is primarily of the small bowel. Metastatic Crohn's disease can appear as cutaneous nodules or a vaginal nodule. The investigations are important for Crohn's disease. And what are the investigations we're talking about? Number one, look for anemia, electrolyte abnormalities, look for low albumin level. Why? Because these patients are losing protein. Look for vitamin B12 deficiency, look for folate levels, right? So these are the important biochemical markers or hematological markers which are required in these patients. Number two, CRP level may be high. You have an inflammatory marker in the stool, two of them, calprotectin and fecal lactoferrin in stools. Debatable, still not in regular clinical usage, but they are mentioned and they are part of investigative profile, especially in the research scenario, may not be so in the clinical scenario. Plain skygram of the abdomen would help you to tell you whether the patient has got obstruction or the patient has got perforation. Otherwise, in a routine Crohn's disease in the stage of ileitis, a plain skygram of the abdomen doesn't help you. But what helps you? What helps you, which is perhaps one of the most important investigations, is a small bowel contrast study, which we were referring to when we talked about the investigation in general. And if you look at the small bowel contrast study, it could be a small bowel enema, it could be small bowel enteroclysis, it could be very follow through, and what could be used, either thin barium or an oral contrast. And what are we looking for? I'm not going to go to the details, just to mention what we are looking for. Number one, you're looking for the string sign of Cantor, you're looking for the cobblestone appearance, you're looking for strictures, you're looking for fistulas. All these signs could be found in these patients. So, and of course, proximal abnormal dilatations with a thickened bowel wall can all be studied on a small bowel contrast study, but much better done with a CT enterography, which is the investigation of choice. So instead of doing a small bowel simple contrast, you can do a CT contrast and then a CT enterography, and it can demonstrate even the mucosal damage and all layers and pathology of all layers, which may not be demonstrable on a small bowel contrast study. So if you look at the investigation of choice, it is probably a CT enterography, but there is a place for MRI also, right? And that is, it may be superior to CT scan for interpretation of intestinal pathology. That is now what they are understanding more and more commonly. So now it is a toss between CT enterography and MR enterography. There are instances where one may be better than the other. A simple MRI may be required in patients to demonstrate abdominal fistulization, pelvic, perianal disease. The MRI helps you in all these patients, right? Endoscopy again helps you in the form that it can take a biopsy. So it is providing a histopathological diagnosis. And endoscopy, which can provide histological diagnosis, can be with upper GI endoscopy, a colonoscopy, or a sigmoidoscopy. A capsule endoscopy does not give you the benefit of providing a biopsy specimen, but otherwise it helps you in delineating the process. And then, of course, a sinogram. If you got a sinus in the abdomen or sinus perineal region, the sinogram helps you. What about the treatment? The mainstay of treatment as of now to start treatment is steroids, and that the mainstay which is for inducing remission. What are you looking at in Crohn's disease? You're looking at inducing remission and then maintaining the remission. Two important aims: induce and maintain remission. So how do you do that? Steroids. They are very good for inducing, but they are not indicated for maintenance therapy. Why? Long-term steroid use, we all know, have got a lot of potential complications. So good for induction, not for maintenance of remission. That's why mainly in non-obstructive stage of the disease, it helps you. Mainly in the non-obstructive stage of the disease. Seen in 70 to 80% of moderate and severe disease patients, the steroid response is very good in this group of patients who have got the moderate to severe Crohn's disease. And how do you use it? As short courses with early tapering of doses. Why? You want early tapering because you want to prevent systemic toxicity. Oral prednisolone, 40 milligram, is one of the drugs preferred, either as a short-acting or a long-acting prednisolone. Oral enteric-coated ileal release preparations, which are now preferred, like budesonide. Why? The advantage is that it's going to be released only in the ileum into the portal circulation. So the systemic toxicity is reduced with such preparation. So if at all you want to use steroid, which we have to, then a preferred would be an oral enteric-coated ileal release steroid preparation. Or it can also be used as an enema in the rectum. So steroids can be used orally as enteric-coated oral tablet or as an enema. The second group of drugs are the aminosalicylates, and among these, the 5-ASA is one which is very commonly used, and mainly for chronic disease. It doesn't have any role to play in the small bowel Crohn's. Antibiotics, are they indicated in Crohn's disease? Yes. If the patient has got abscess inside the abdomen or the patient got a perianal disease, medical therapy or antibiotic therapy would be indicated. And the two common drugs, number one, metronidazole and ciprofloxacin, can be used, but you have to be careful. Don't use them for a long period of time because both of them have got their own complications. In one, there could be peripheral neuropathy. In the other, there could be Achilles tendinitis or even tendon rupture. The last group of drugs, not the last, the second last group of drugs are immunomodulators. And why are they indicated? Number one, we just now said for inducing remission, but not for maintenance therapy steroids, right? So what happens for maintenance therapy? You could be having immunomodulators. So they act as additives to steroids and they have a steroid sparing effect. Minimum 12-week therapy should be given. And they are good for maintenance therapy. We just now said that. And the three drugs which are commonly used, number one, as a thioprin, as a standard maintenance therapy, or its active metabolite, the 6-mercaptopurine, or you can have a cyclosporin as a short course intravenous administration, or methotrexate, both helpful in inducing and maintaining remissions in Crohn's disease. So immunomodulators are good for maintenance therapy and can be carried out for minimum 12 weeks of therapy. But the favored drugs as of now are the monoclonal antibodies, and the current indication of monoclonal antibodies include number one, induction and maintenance of remission for moderate to severe disease. Look, mild Crohn's doesn't have a major problem. It can be controlled with just drugs. But the major problem comes in moderate to severe disease with a lot of complications. There is a scenario or there could be a buildup of complications and often morbid and mortal. So in these patients, an early remission is required and maintaining the remission is required. So monoclonal antibodies probably help in induction and maintenance of remission in these more severe cases of patients with moderate and severe disease. And early use is usually advisable because they would probably be helping in a number of patients to prevent surgery. Those patients who are put on early MCAs, the surgery may not be required. Resistant and refractory cases, there's no other option. You have to use MCA. So the indications of MCA basically is induction and maintenance of remission. Early use would obviate the need for surgery, and resistant refractory cases, they require MCAs. It is contraindicated. MCA should now be given in those patients where there's active infection inside the abdomen, or the patient's got tuberculosis, or the patient got a past history of malignancy. In these scenarios, do not use a MCA. And what are the drugs used MCA? The most common and the hallmark was infliximab, which is a murine chimeric MCA against tumor necrosis factor alpha. Remember, all the drugs, all the MCAs which are used are nothing but tumor necrosis factor alpha antibodies. They're all monoclonal antibodies against TNF-alpha. So one is the murine source, that is infliximab, especially for refractory case, for fistulas, acceptable long-term results, and the current clinical practice, because this is the most commonly used drug among the MCAs even now, and that is 5 milligram per kilogram IV, once at 0 week, once second week, once 6 weeks. So 3 doses, followed by maintenance IV infusion every 8 weeks. On average, the effect lasts for 12 weeks. The second is the antibody against T1 necrosis factor alpha, which is available from a human source, and that is adlimumab, right? Subcutaneously every 1 to 2 weeks. Then you can have third generation. Now, these are antibodies against integrin. These are not antibodies against tumor necrosis factor. These are antibodies against integrin. And all these antibodies, they prevent leukocyte migration. Tacrolimus, mycophenolate, mofetil are drugs which are very commonly used in any kind of transplant protocols. Renal transplant, pancreatic transplant, liver transplant, etc., etc., etc. They are very good immune modulators, immune depressants. So these are also drugs which have been tried from time to time, even in Crohn's disease, with debatable results. Nutritional support is a very, very important, and this, I'm not going to go to the details of this, that would be covered in surgical nutrition, but just remember, nutritional support is required, number one, to maintain the calorie of these patients, and number two, to prevent these patients going into negative nitrogen balance. So both the conditions are important. What about the treatment part? Number one, endoscopic balloon dilatation, which is really a non-surgical part. Endoscopic part is now being tried more and more often. What is important is that that particular stricture should be reachable by the enteroscope or colonoscope. So if it is approachable and there is no active inflammation or ulceration, go ahead and do a balloon dilatation. But if there is active inflammation, there is ulceration, not approachable, this does not come into play. So the basic management of Crohn's disease is either a step approach, a step up, or a top-down approach. What a step approach means basically means I start with steroids. I find the patient not really reacting or not giving me the desired effect, clinical response. Then I shift to what? Immunomodulator. I'm still not getting response. Then I shift to monoclonal antibody. That means I'm going up the scale using the lesser or rather more commonly used drugs, which are probably not as beneficial as the higher end. So I start with steroid, then I go to immunomodulator, and then ultimately then I go to MCA. The other is I start immediately with MCA. That is the first drug I'm going to use. Why? Because I want to have an aggressive early remission. That is a top-down approach. So top-down basically is starting with MCAs and coming down. A step up approach is starting with steroids and going up. So top-down is probably now being preferred by more and more people, but the only problem with this is a very, very costly affair. Why MCAs are not exactly cheap. They are very costly drug. So you may like to go in for a top-down, you may like to go in for a step approach, but surgery has a major role to play in step-up approach. Why? Because by the time you reach to MCA, the patient already developed complications. But the role of surgery in top-down is still debatable. We still don't know. So what is the surgery? Surgery is a symptomatic treatment. Remember that it is not curative. Surgery is not curative. It does not cure CD. It is basically a symptomatic treatment. And if you look at the incidence, 70% of patients with Crohn's disease as of today would require bowel resection at some point of time. And among these, 20 to 80% would require a second resection. So re-resection for recrudescences would be 20% at 5 years and 80% 20 years. That means surgery plays a major role in CD management, albeit it is only for the symptomatic relief, but nevertheless, it is an important component of management. The indications, when do you do surgery in every patient? No, absolutely not. You should have a surgical indication. Like, for example, the patient has recurrent acute intestinal obstruction or cervical intestinal obstruction. The patient has perforation. The medical treatment has failed. The steroid dependent so much that you don't want this patient more on steroid, go ahead and do surgery. Fistulization or perianal disease. In all these, you would require surgery. And I said earlier, recurrences after surgery is not uncommon. It can be as high as 80% and as low as 20%. So what is responsible for the recurrence of after surgery? Is it a residual disease in the suture line? No, it's not that. It's not that. So that doesn't mean, that basically means it's not that you have not removed the part. You may have removed whatever is pathological, agreed, but the disease process is not a localized process. That means the patient is having a fresh manifestation at some other point. And what is the surgery advice for Crohn's disease? It can be done by open or laparoscopically. We'll just enumerate what can be done. We're not going to go to the details as far as you're concerned. That's beyond your scope. Number one, you have opened a patient, suspected appendicitis, and there you suspect now you don't have appendicitis, you got a Crohn's disease. What do you do? So the decision making becomes very important as far as surgery is concerned in scenarios where you're operating for suspected appendicitis and you find Crohn's disease. In what form? Number one, terminal ileitis. You see a patient having inflammation terminal ileitis, you suspect CD. What do? What should I do now? My concern would be, is it really CD? Number two, if it is Crohn's disease, is it going to respond to medical therapy? That means whether it's complicated or uncomplicated. If it is uncomplicated, simple inflammation, don't do anything. Just come out. It's going to respond to medical therapy. But if you find there's early stricture formation or adhesion formation, or you find a lot of fat distribution in the mesentery, then you suspect that probably at a later point in time, this patient may require surgery. There you have to decide whether at this point in time you would like to go in and excite that. Then look for the other parts of the bowel, whether it is only a localized segment involvement or multiple segment involvement. So these are the concerns when you really decide, you have to decide when you have a terminal ileitis popping up in your face in a patient where you have done surgery for appendicitis and you don't find appendicitis and you find probably suspected Crohn's disease. Number two, the second concern is whether you should do an appendectomy in a patient with Crohn's disease. Only do it when the appendix is really inflamed, otherwise don't do it. Why? Because if you have appendectomy in a Crohn's patient, the chance of having a fistulization is very, very high. Excisional procedure is the second group of surgery required, and these are removing that particular segment. And because we said earlier, the most common is ileocecal, so do a hemicolectomy, ileocecal resection, a segmental resection. That means the segment of the ileum is removed or a segment of jejunum is removed. You can be doing a proctocolectomy or a colectomy with ileorectal anastomosis, or you have a simple stricture, you can be doing a stricturoplasty. That means you cut the stricture across long axis and stitch it transversely, stricturoplasty. Or you can do a temporary loop ileostomy. The patient is so morbid and has come with acute cell obstruction. If you don't do something, the patient is going to die. So what do you do? And if you're going to do a major surgery, the patient is going to die. So what do? You just create a loop ileostomy. Let the patient build himself up. At least you've relieved the obstruction. If the obstruction has been relieved, this patient would gradually gain weight, gain calories, so on and so forth, and probably he may be able to face a second surgery better. So temporary loop ileostomy. And if you got a perianal disease, you have to manage it accordingly. The drainage of anal abscess, or can do a fistulectomy and so on and so forth. I think that is all we want to talk about today. Thank you for your time. And we'll continue with small bowel disease next Friday at the same time, 8 o'clock. Until then, if you want to look for more educational videos and lectures on important surgical topics we already covered, which includes tuberculosis, gallbladder stones, and so on and so forth, you can either tag on to my website, sinhaji.com, or you can go to my YouTube Prime channel. Just type in Rajiv Sinha and you'll find these videos there. Almost, I think, 55 or 56 of these educative videos there, and you can easily run through them. They would be very good instructional material for you. I think that would be all. If you have any questions, you can post them on that channel, or you can post them on my WhatsApp number. You can find my number. Just post them, and I'll be willing to answer those questions for you next time. Thank you for your time.